Well, thank you, Doris. That's very kind. My publicist will be very happy. So let's get to the topic at hand. So today we're going to talk about assisted death. So I want to take 2 minutes to remind you of the background. Most people here know what's up in Canada, but just a little refresher that in February 2015, the Supreme Court of Canada struck down parts of the law that it was until that point illegal to assist with suicide in Canada. And they said that specifically that physicians, and that later became nurse practitioners as well, could assist in death when it was appropriate. Essentially, the court ruled that sanctity of life includes passage into death, a very important legal concept. And they said that those with severe and irremediable suffering should not be condemned to intolerable suffering, that we don't have a duty to live if we don't want to. As you know, there was a delay granted by the court for legislation to come in, and eventually in June 2016, the Government of Canada passed Bill C-14. And in that law, the controversial part of that law is it said that death must be reasonably foreseeable in adults for people to be eligible. A little different from the court ruling, and we'll talk about that a bit. And what that means practically is that some people, specifically people with mental illness, people with dementia, children who would want assisted death are excluded from the law presently, but there's a committee that's now reviewing that, so the law will be reviewed and maybe modified at some point. Last week there was the first national report, statistical report on MAID to death, to date. Oh, how's that for a Freudian slip? To death. So we found out the numbers are not great because not every jurisdiction reports or keeps data as well as they should, but we found that in 2016, 970 people in Canada availed themselves to the right to assisted death. That's 0.6% of deaths. People had predicted it would be 2, 3, 4%. So far, it's 0.6%. Half the deaths were in Quebec, which had its law kicked in 6 months earlier than in the rest of Canada, so that's understandable. So 463 in Quebec, 507 in the rest of Canada. The average age of people who chose assisted death was 72, so a more elderly population, and half of those were in hospital, but that varies dramatically by region of the country. Some provinces, most deaths are at home, some, all of them are in hospital. 57% of people had cancer as their underlying illness. 23% had neurological conditions such as MS and ALS, and 11% heart or respiratory illnesses like COPD or heart failure. And we're going to get much more statistical data about Ontario in particular in our first presentation. So what I'm going to do is present our 5 panelists. We have a all-star cast to talk about this issue today. It's going to start with, as I said, some numbers, a lot of data, and then each of the presenters will speak briefly on a specific topic, and then we'll have a conversation, and we have mics in the room. We'll invite you to join in the conversation. Et comme on est en Ontario, et comme je suis franco-ontarien, évidemment, les questions sont le bienvenu en français. Je suis content de traduire, ou si vous voulez parler en français, c'est évidemment le bienvenu en Ontario. Ah, bienvenue. Je viens de North Bay, alors je dois noter ça. Voilà. So our first presenter is Dr. Dirk Huyer. He's Ontario's chief coroner. He's been actively involved in Ontario's response to medical assistance in dying since early 2016, where he's been leading in particular the reporting and oversight process. Today, Dr. Huyer is going to give us a sense of where we're at with MAID and do a deep dive into the numbers, which you'll find quite fascinating, and he'll touch on some of the challenges. After him, we'll hear from Maureen Taylor. She's a physician assistant at Michael Garron Hospital in Toronto. You will know Maureen from having seen her in the media. She was married to Dr. Donald Lowe, who died of a brain tumor in September 2013 and really was instrumental in getting Canada's assisted dying law. During his illness, Dr. Lowe was quite outspoken in his advocacy for assisted death and for palliative care. And Maureen has continued that advocacy to this day. Among other things, she's served as the co-chair of the Provincial Territorial Advisory Group on MAID. She'll talk to us today about some of the future challenges, what's not in the legislation. And I'm actually presenting people in order. So in the middle, Debra Bournes is the Chief Nursing Executive and VP of Clinical Programs at the Ottawa Hospital. She worked with a broad range of stakeholders to design and implement the hospital's MAID program, one that supports patients, families, and team members who participate. Sally Bean is the Director of Ethics of the Ethics Centre and Policy Advisor at Sunnybrook Health Sciences Centre here in Toronto. She's also co-chair of the University of Toronto Joint Centre for Bioethics MAID Implementation Task Force. How do you fit all that on a business card? I could barely say it in a breath. Sally's going to talk to us about some of the ethical challenges of MAID, so she'll have virtually nothing to say, I'm guessing. And finally, Carol Timmings, as you know, needs no introduction in this room. She's the president of RNAO. She's also the chief nursing officer and director of child and health and development at Toronto Public Health. She'll discuss, among other things, the duty to refer. So, Dr. Huyer, if you could kick us off, and we'll get started.
Morning. It's a real honor to be here. It's not often that I have the opportunity to take charge of the room when Mr. Picard is present, so I'll have to be very careful what I say. I made quick notes so that I would, shamelessly say everything that he said and has said. So I just wanted to talk a little bit about where. There we go. Whoops, sorry. Just talk a bit about what we're doing here in Ontario, specifically the Office of the Chief Coroner, and just give a quick overview and a perspective of our role, how we get involved, and then talk a little bit about some of our numbers. So Mr. Picard's talked a little bit about what's gone on in Canadian-wise, but I'm going to talk about today's numbers and what's gone on over the past number of months. So when we look at the role that we provide, it's very unique to and very different from our typical role as the Office of the Chief Coroner, because our job is to investigate deaths. And within that job, we're trying to understand the circumstances of that death, then to try to identify any particular issues or systemic concerns that can help to reduce future deaths. Clearly, that's different in the two roles, right? As the Freudian slip that was made earlier, the cause of death is not challenging in the situations that we're involved with when MAID happens, and we're not trying to prevent future deaths at all. So it's really a real different role that we're providing, and we're providing what would be an oversight role. And that, again, is very unique. Well, it's contrary to what we usually do, because we are not the overseers of your practice, of physicians' practices, of anybody's practices, because our role is always collaborative and cooperative and looking to, again, improve things for the future and lessons learned. So having a role as an oversight put us in a very awkward and unusual scenario. We don't oversee the number of times that interosseous lines are put in. We don't oversee the number of times that hip surgical procedures are repaired. So it's very unique, because the regulatory bodies would typically be doing that. Having said that, we are in the role. And there's a number of reasons why we are, and I'm not going to talk much about that today. But what I've recognized is that we do need this, and we've all recognized that we do need this. Many people have articulated this. The Supreme Court of Canada, in their ruling, talked about the need for care and safeguards and protection for those who may be vulnerable, and also to ensure that this process, which has significant serious outcome, is appropriately monitored and known. So people need to know what's going on. People need to understand where it's going on, people need to understand how it's going on, and people need to be sure that safeguards are in place and are being evaluated to be followed to make sure that the vulnerable aren't suffering. And why? Why do we need to know that? Well, it's how to potentially inform future changes. So the legislation changes may benefit from our understanding and the data and the information. The public need to understand what's occurring. And those who may want to avail themselves of this medical procedure or process, or however would be described by different people, this opportunity should be able to understand what's going on. So it also can help with clinical, and so on the immediate case-by-case level, we provide lessons learned to the clinicians if there are some, and also provide feedback to the families. So, what do we do? Well, we really need to recognize the intrusiveness of our office. And there are many that say, oh my goodness, the coroner's going to be involved. That's going to be a patient access block. That's going to limit people doing it because people aren't going to want to have the coroner looking into things. And so when we first started, I would say we were more intrusive than we are now. So we used to seize every deceased person, transfer them into our care, and do an examination. Because that's what our legislative and our policies and our processes say that we must do, and so we must follow legislation. So we recognize, though, we continue to evolve, and we're still evolving and learning and taking feedback. We recognize that that was quite intrusive, and we weren't, there was no benefit to the investigation. So we weren't going to do things that are intrusive that aren't beneficial. So we flexed, shall we say, in a way that made most sense. And so we really are looking to balance the very challenging part of our potential intrusion into the clinicians, but more importantly, the family's time around the death of the person, and really carefully make sure that we provide the roles that we think we need to do in contrast to, and balancing that off with the challenges that are faced with family members. So our role is one of compliance. And so this is the way I kind of structurally lay it out so people can understand what we're doing. We need to have an area within the government, specifically in Ontario right now, and other provinces and territories. As André pointed out, the reporting is variable across Canada. We feel very strongly that we want to be reporting in a very detailed manner to help to have people understand what's going on and open that transparently as we can. So reporting, they need to be compliant with reporting the data that we need. Number two, need to be compliant with legislation. Serious outcome. We must be ensuring that things are occurring following the legislation. And doesn't say that, I'm not saying the legislation's perfect, I'm not espousing any of that, but there is legislation and we need to follow that, and then we need to learn from that to potentially improve changes as future happens. Documentation, we need to ensure that these cases, because the implications are thoroughly and effectively and appropriately documented. And then finally, from a medical point of view. So do the medical criteria fit with what's expected? And again, are there opportunities we can learn from that? So right now, and I'm going to just talk you quickly through this and then go into some numbers. Right now, I have these incredible responsibilities that I take very seriously. And one of those is that I administer the Coroners Act in Ontario. So I'm responsible. It's kind of scary they actually appointed me. I still kind of wonder about this. 15,000 people we're investigating per year. We're the largest in North America. Again, I'm like, really, me? And so, but I make the decisions about how that act, with advice, obviously, but how the act would be administered. And these deaths, by the medical or healthcare perspective, are not natural deaths. Just taking it at a scientific level, these deaths occur because of medications. That is not natural. I'm not trying to say anything about that, but just at the scientific level. And so in the current world, in the current legislation, our legislation specifically says that any death that occurs from a non-natural way must be investigated. Now, take that out of context now into MAID. The reason that we're getting involved in all natural deaths is because there's an opportunity to make recommendations to make things better. That doesn't jive, right? The two just don't connect. Because we do want to make the practice better, but we're not trying to prevent deaths, as I said earlier. So it's an important consideration, but that's how these cases must be reported to us right now legislatively, and that's in the current framework. So they come into our area of practice as a non-natural death. And so then we have to follow our legislation, which says examination and do the death certificate. So we're responsible for those things, and ultimately we're trying to find 5 answers. So what we do very quickly, we talk to the clinician, we talk to the family, we review all the records, and then, as I say, we provide information as necessary. We have rarely involved and done further examination, such as an autopsy, and I'm not going to spend a lot of time talking about this now. Cause and manner of death, under the current legal framework, because they are coming into us as a non-natural death, I can't send them out as a natural death. It just isn't logical. My science doesn't make sense. So right now, they are being classified by us in Ontario as drug toxicity deaths, as the cause, and then the manner is being provided as suicide. That's in our current world, because It is what we've interpreted to be in Ontario as an intentional act of the person knowing the probable consequences, and that's their death. The act starts with the request and proceeds through to their death. That's the way we are framing it right now. But hold your frustration and your concern with that, because I will tell you where we're going to, I believe, although the legislation has not been passed. Family, we disclose that to the family. We talk that through with the family. We explain it. We have not seen any insurance challenges with this. I've phoned insurance companies. We've talked them through. There have not been challenges. But I totally understand it. André asked earlier about, is there going to be a bump in suicide in Ontario's statistics? There absolutely is, but there'll be an asterisk saying that this number includes such and such made cases, so that we will effectively point that out, and we tell the families that as well. So what's pending? We have new legislation. It's big and long. Don't worry about reading this. But it's pending legislation in Ontario, which essentially, I'm going to flip forward to one. The clause that says it's non-natural must be reported to us, MAID will be excluded from that. So if you read from that and you take the broader process of that, that's saying legislatively, these are not being identified as non-natural deaths, if you follow me. So moving it back, we still, though, need to collect that information. Our legislation in Ontario is the best way for us to collect that information right now. So what I've done is I've developed a team or a department that is separate from my investigation team. They are the ones that receive the reports. They are the ones that get the data. They are the ones that get all this perspective. And if something raises concern, then they will pass that to the investigative team. And that happens rarely. Having said that, the public, the clinicians, the families, they don't know that, because it still seems very much like the coroner's office is there. We get that, and so I kept the team to a small number. It's 6 nurses who are doing the work in our doctor-led position. And the reality is it makes perfect sense, right? And so I've just expanded from 4 to 6 nurses, and so it's a small team, because we believe that we need to have this centralized. We want special expertise. We want people to develop, and it's phenomenally interesting as the team is developing and maturing and thinking about broader issues like quality, education, thinking about the broader stuff. So it's really quite neat. But it means that people do have to tell us, but this is the new legislation. And so then we will no longer be responsible for the death certificate. So guess what? We're not going to write suicide unless we're investigating those cases. We may or may not. That's up to the investigator. But the general ones, the clinician will be doing it. And it's my understanding that the advice will be provided to the clinician to put the disease, condition, or illness that led to the request. And MAID won't be noted at all. So quickly through the stats, because Andre's going to give me the hook soon. As of March 31st, we were involved in 367 cases. As of today, 413, well, as of this morning before I left, 413. Of those, the vast majority, 366, were clinician administered. There was an error in our reporting before, if you've heard this before. We believe there was 3, but there was an error in reporting. It's 1, as far as I know. We are going to double check that. And right now, in 2017, the average per month is 15. And if you extrapolate that out, back to Andre's numbers, and Maureen pointed this out to me in our preparation call, if you take 15 per week, it'll give approximately 0.8% of deaths in Ontario, if that's the number. It was 6 per week up until the new year, and it's been 15 per week since, just to give you an idea. About 120 clinicians have been involved to administer. In the grouping of assessors and providers, nurse practitioners have been involved in 10 cases that we're aware of. It may be more. We try to capture it. We haven't captured quite as accurately in the early days as we do now, but we know nurse practitioners, and there's been many registered nurses and registered RPNs involved in the care, in the teams, and all over the place, and the assessments and a number of other things supporting throughout. So very similar to what André talked about. I'm not going to delve down into these numbers, but it's a fairly similar breakdown. Now, let me give you one perspective out of this. So most people, when you talk in the public, think about medical assistance in dying and somebody at their end stage of death where they're suffering horribly from that particular disease. So everything lines together. The disease is going to cause their death. The disease is what's caused their decline. The disease is what's led to their horrible suffering. That's the majority. But there are a number of cases that we're involved with, which would fit in the other area, which is a smaller percentage, where they have a condition that has, and I'll give you one example, a 95-year-old man, the family have given me permission to talk about this, a 95-year-old man who had macular degeneration and was becoming deaf, both taking away significant parts of his life, his crossword, and he was falling. He couldn't do what he wanted to do anymore, which were his big, big things. And he was falling because he couldn't see or hear most of the scene. But those were his conditions. Was his death reasonably foreseeable? Thank you, Maureen. He's 95. If I was called by the police and said, we're at this house of a 95-year-old gentleman who died in his sleep last night, what are you going to do, Dirk? Well, it's a natural death. It's fine. We wouldn't get involved. So it's reasonably foreseeable. But if you think about that, that's completely outside of the model, or the type of case people are thinking about. So there are a number of other cases, and they should be cases that should be considered. But that's, again, an example, just to get you to think a little bit. Where is the setting? Our numbers are fairly significant outside of hospital and really variable, but more outside hospital and private residence. Age, 73. So as Andre said, 72 in the 2016 data. Oldest of ours was, we've had a younger one just recently than 35. I won't tell you the age because that would potentially identify somebody. And the breakdown, it's around 50, 52% gender-wise, not that different, seriously. Andre's already talked about this, but just I'm throwing the numbers down from the other jurisdictions of Netherlands around 3.75%, Belgium 1.8%, and then Oregon 0.67%. They all have different criteria, so it's hard to compare. It just gives you an idea of what's going on in other places. So I've talked about the team. I have to tell you, they're phenomenal people, and it's really neat to watch this all develop. And I'm going to stop at that point. I do have lessons learned, but I think we'll stop, and because I think a number of these will come through in the conversation, and I've taken way more time than I was allowed to have. So thank you very much.
Okay. Thank you very much again for inviting me. Thank you, Doris, for thinking of me for this event. I was here a couple of years ago. I want to say right off the bat, am I happy that Canada has legislation that allows people the option of an assisted death? Absolutely. If this present legislation had been in effect when my husband was diagnosed, he would have met the criteria, hands down. He was a slam dunk, right? So you might think, well, why are you still yammering on about how the legislation isn't enough? And it's because of my work on the Provincial Territorial panel that I continue to be thankful for the legislation as it is, but I don't think it goes far enough, and I think we need work. So let me address some of the challenges, and some of these are future challenges, but some of them are challenges right now, and I'm sure that the rest of the panel has even more firsthand experience with these challenges, but I'll just list some. As Andre hinted, that insertion of the phrase reasonably foreseeable death, which wasn't in the Carter decision from the Supreme Court, is, I think, the government's way of saying you have to have a terminal illness without actually saying you have to have a terminal illness. And this is being interpreted differently, physician to physician, nurse practitioner to nurse practitioner. And so that's a problem. I also know of physicians who think they've got a patient who meets this criteria, but when they get the CPSO and then the CMPA lawyers on the phone, they're told, I don't think so, I wouldn't do that one. Death, tell them to come back when they're suffering more. And that leads me to the definition of intolerable suffering. In Oregon and Washington and the other US states, which have the narrowest criteria in the world for assisted death, if you meet the prognosis of a 6 month, you have 6 months or less to live, the physician is allowed to write you a prescription, and we get it, that's an oral medication. You get that prescription filled, you put it in the bedside table, and you decide when your suffering is intolerable, or if it's ever intolerable. A third of people in Oregon never take the medication. Some physicians are interpreting this. If you say, I want to be assessed for MAID and I will want it, but I want to go to my daughter's wedding this summer, the physician may say, if you feel well enough to go to a wedding, you're not suffering intolerably. This is wrong. The Supreme Court decision clearly said it's the patient who gets to decide what intolerable suffering is, not the clinician. Religious hospitals, hospices, long-term care facilities are saying that MAID cannot be done on their premises, and the Ontario government has supported them, I think even with legislation, to help them to continue to refuse to provide MAID. What we don't know is, are they performing an effective transfer of those patients to another willing facility or provider? Maybe other people can talk about this, but at the hospital I work in, down the road from St. Michael's Hospital, we don't have a lot of beds empty to take people from St. Michael's Hospital just to have MAID. And nor do we think it's fair that we become the hospital for MAID in East Toronto. So that's a challenge. We could get into, should taxpayer-funded hospitals be able to refuse people a service that is legal? But I'll leave that for somebody else. So effective referral, this matters to you. Both your college as well as the College for Physicians and Surgeons in Ontario are very clear that while you have the right to refuse because of conscientious objection to perform MAID, you must have a means of transferring that patient to someone else who is willing. Now, this has been fought by the Christian Dental and Medical Group. I'm sorry, I don't have the right name. They're fighting this. They say that that is tantamount to murdering people. They think that if they transfer you to someone who's willing to do it, then they've also participated in the assisted suicide. So that struggle is going on, but your colleges already are very clear on this point. You cannot abandon the patient. You must continue to provide the ancillary care, and you must find a way to transfer that patient. The Ontario government is coming out with, I want to get the name right, a care coordination service. It's going to be a 1-800 number and a website that clinicians will be able to give to the patient who requests MAID, and then the patient will be able to contact that and supposedly be put in touch with a willing provider. Lots of my patients who don't speak English and don't use the internet might not find that useful, but anyway, it's movement. The other challenges right now I'm hearing from doctors who say there is an inordinate amount of paperwork around this, as we've heard why there should be, but there's not a lot of remuneration on the other end, and nobody is in this to make any money. But I know a physician who was recently asked, could he go to North Bay just to interview the patient and talk about assisted death with them, review all of their medical files, come back home, and then go back to provide MAID in the future. And I think for that, it's like $100. I don't know. It's around $100. So he was just saying, you know what, I can't go to, it's a 3-hour drive each way. And so that's a challenge, which brings us to the geographic challenges. You didn't break it down, but I'm sure you have the numbers around, rural areas in different parts of Ontario. It would be a challenge for people to access MAID in rural parts of Ontario where the only hospital is a Catholic hospital. That's going to be a challenge. And we don't really have a lot of data on that yet. Future challenges, as André hinted, the federal government has put together a Council of Canadian Academies panels to look at the 3 issues that were not dealt with in the legislation, and they've promised to review them. So one is mental illness as a primary condition. Many of you will be familiar with the young man from the Windsor area who recently committed suicide after saying publicly he wanted MAID. I was very relieved to find out that it sounds like he didn't have a violent death. So mental illness is one. Advanced directives is another. If the way the legislation stands now, if you're diagnosed with dementia, your death is not reasonably foreseeable, so you won't qualify. When you progress to the stage where your death would be reasonably foreseeable, you've probably lost capacity, and then you can't get MAID. So this is a big one. It's in the Globe and Mail today. The person that the federal government has asked to lead that arm of the review, Harvey Schipper, has gone on record in the past in the Globe saying that he felt that the arguments put forward by assisted dying advocates were akin to those the Nazi regime used to justify their eugenics program and the Holocaust. Why the federal government, I don't mind if he's on the panel as a member, but why they put him in charge of assisted dying with advanced directives, I'm not sure. And then the third one is mature minors. I had the, this is one that's hard. I think they're all hard. But I actually got to hear a bioethicist from Sick Kids talk about mature minors yesterday in Grand Rounds. And it was very interesting to see where the pediatric community is coming. Right now in Ontario, mature minors are allowed to make decisions about their own health care, even if it's a decision to withdraw treatment leading to death. So they're asking, how can we then deny them the ability to ask for MAID? So those are the things that are there in the future. Right now we know the BC Civil Liberties Association does have a patient who is going to go to the Supreme Court probably eventually to challenge that notion of reasonably foreseeable death. So future court cases, future expert panels, and as you can see, it's still a hot mess. Thank you very much.
Oh, there we go. So thank you, Doris, for convincing me to come and do this. I hesitated because I thought, what do I have to offer? But what I have to offer is the practical side of this. There's a lot of things that are a hot mess, and I could talk with Maureen about it all day, but there are some places where it is working well. So I want to talk a little bit about that, but also the challenges from a more operational point of view that we still have that actually came up in both of your talks to some degree. So at the Ottawa Hospital, we have a really solid team of people, staff and physicians who have volunteered to be part of our MAID team. There's registered nurses, physicians, social workers, and psychologists. And they really stepped forward when the path to this was unclear at best, because we hadn't done this before in Canada, and we knew a little bit about what had happened in other countries. And we had to develop a process, and very quickly, we did a lot of anticipatory work of the legislation, and our ethicists and our physicians and a whole interdisciplinary team came together to look at what would our policy say. We never started with, are we going to do this? We started with when and how is this going to happen as we move forward, and that was the stance that our organization took. So we had a group that looked at policy and a group that looked at, well, how do you do this? Right from who needs to be there, how's it going to happen, where is it going to happen, and what are we going to use? What's the drug cocktail, because it hadn't been done here. And so we put something together. In this team, we have had a team of volunteers, and things have changed over time. As the legislation came into process, as practice guidelines changed, we've had to adjust. And it's been, right from our first court-ordered case that was under a cone of silence to where we are today. And that cone of silence still affects the team because we haven't really talked about it a lot publicly in our organization, and more the team members are standing up and saying, I'm on the team. And that is another whole, I think, discussion. But what we have today is what I think is a very patient-centered pathway. It's responsive, it's compassionate, it's informative, it's respectful of patient preferences. I had one of the nurses say to me, whatever they ask for, we do. And some of them described it as, in some cases, it's like a ceremony, like a wedding or a funeral, and there's a lot of people there, and we do it in a way that it's what the patient wants. So in the beginning, we thought, you know what, we're going to do it in our outpatient clinic on Saturday mornings. That's when patients and families tell us is the most convenient. That decision lasted about a nanosecond. As soon as someone said, I want to do it at home, or I want to do it on the inpatient unit where I happen to be already. And so it's been very, very flexible. And I think the other piece that we've added that wasn't part of the legislation or one of the legislative requirements is very strong psychosocial support for these patients and families. We have social workers who are extremely involved in working with this, and in some cases do pre-assessments. And also the nurse's role in some of this is also some of that support. And so we've done some evaluation, very formal evaluation with the team, but also some with patients and families, because what we have is a 28-day pathway. And our goal is that from the time we receive a written request, that the request will be carried out within 28 days, if that's how the patient and family want it. And sometimes, you know what, they want it to go a little bit further. Pretty much all of our cases have happened within about 20 or 21 days. Some have happened within that 10-day window where there's supposed to be that 10-day waiting period because they were worried the patient was going to lose capacity if we waited too long. So all of that happening. Doris asked me to talk specifically about what the nursing role is in this. To this point, we haven't had our nurse practitioners involved. The physicians have been doing the assessments and the procedures, but we have registered nurses on the team. The very first MAID procedure that we did, we had a volunteer from our corporate clinical nursing practice committee who had also been involved on the working groups that looked at what's the policy going to be and what's the operational pieces going to be. And now we have a group of nurses who are from I think 100% right now, the critical care unit. And when I say to them, why are you doing this? They talk about all of the horrible deaths that they see. And that this is a way of participating in a very peaceful and beautiful death. And they find it very rewarding. And you know, there's a whole lot of things that go with participating on these teams, but that is why they do it. And so what we have at the Ottawa Hospital is essentially a one-page guideline, which is very much based on the College of Nurses of Ontario guidelines, which is just a quick, here's what you need to know if you're participating in MAID at the Ottawa Hospital. The nurses don't do pre-assessments with the patients. They don't meet them until that day, but they do spend time in the days leading up to the procedure once they know that they're going to be involved in that case, reviewing all the documentation, the social work notes, the physician's notes, and they go through a checklist to ensure they've done their due diligence, that all the legal requirements have been met, and they have specific documentation guidelines. They also participate in our resiliency program, which I'll tell you in a moment. But on the day of the procedure, the whole team comes together before the patient and family get there, and they review everything again. They start their documentation process. They make sure things are set up in the way that it needs to be, and they rehearse how it's going to be. Some of them talk about performance anxiety because you can have 30 people in a room with a family big family who wants to be there, and they walk through how it's going to go because they're worried that they're going to try and put the intravenous in and it's not going to work with 30 people looking. Hasn't happened yet, but it is. Those are the things that they worry about because they want it to be perfect for the patients and for their family members. So I spent the last couple of weeks when I knew I was coming here talking to different participants on the team, and I want to read you what one nurse wrote about the first time she participated. She says, once I knew I would be part of the first team, I second-guessed myself. Was I going to be able to do this? Would I be able to handle this emotionally? It was a situation of unknowns and unfamiliar territory for all of us. Sorry, I have a cold. In the days leading up to the procedure, I rationalized with myself that despite my concerns, all I could do was to be there for them, my team, the patient, the family. I kept reminding myself that no matter how difficult it may be, I was there for whatever they needed, whatever they asked for, and to be there. Not just physically, but to be present in the moment. They deserved that. I knew I had the support of many, and I was not alone. It was a privilege to be part of the team, and an honor to be there during someone's final moments. That's why I did it. I remember when I first met the family that day, I immediately felt the gravity of how difficult this patient's journey must have been. The diagnosis, the treatments, the failures, the symptoms of disease becoming so intolerable. It provided me a sudden clarity in that first minute. I was immediately humbled by how hard this must have been for the patient to come to this decision, and I admire them for having the courage to take control of a situation that really had, up until that point, afforded them little control. There were the goodbyes, the final words, and a patient's smile preceding the most peaceful and swift ending I could wish for my loved ones. I remember standing there and feeling the weight of their journey and a sense of relief that the patient's choice to end the pain and suffering in this manner was complete. Time almost seemed to stand still after that, going through the motions, completing the required tasks, everyone making sure everyone else was okay. I ensured completion of my duties, and almost in autopilot fashion went to spend some moments on my own to process what had happened. My thought process was analytical. Did I say the right thing? Was I supportive enough? Is the family okay? Could I have done better? My mind was on overload. Of course, these were questions I could not answer in the moment, which definitely affected me. Having an aftercare plan in place was worth every moment I spent thinking about it in the days before. I had cleared my schedule, no appointments, not having to work afterwards. I knew I would need some time for me. I kept myself accountable to this plan, taking time to unwind the unfamiliar energy, and later some time with loved ones to ensure I wasn't alone. I kept my usual plan for the day after and the rest of the week, and in retrospect, surprised myself at how well I could get back to the things, almost to the point where I felt guilty. Looking back, I understand now this was my effective resiliency plan in action, and a sign that the support I'd received from my team and my aftercare plan had done its job. And reflecting back on it after several months, I definitely felt challenged in a way I'd not quite anticipated, and have grown as a nurse because of it, and I would do it again. So what she's referring to is it's a robust staff support through resiliency training that was developed through our psychologist, Dr. Carrie Ritchie, and a psychiatrist, Dr. Carolyn Guerin-Lajoie, who work at our hospital. And they worked with someone at the Department of National Defense, and they adopted their Road to Mental Readiness, I can't speak, resiliency program. And the team, what they said was, we've all participated in people dying, we've given people morphine at the end, we've seen deaths, but it's very different when you have someone in the bed talking to you saying, okay, it's time now. And they didn't say it felt bad, but they were struck and they went away and they needed to be able to process and talk about that. So they developed a program where they talk about that ahead of time. They warn them that it's going to happen, especially if it is their first time. They put into place a resiliency plan for the team, and there's a whole process of check-in before and after about how they're doing, and that's all in the process of evaluating. And it's really been a critical factor for keeping people involved in the process. They don't talk about it as bad. They talk about it as a feeling they don't know what to do with and they're not familiar with, and yet they're extremely committed for all the reasons that I said before. So I'm going to leave it at that with the nursing experience. Happy to take questions later. Some of the challenges that for sure have come up that are similar to what you've said is that we definitely have access problems. I was at an education day last weekend where a patient's daughter talked about, she spent 3 weeks in agony. She is a well-known advocate for a lot of things, very vocal, very strong personality, and trying to get made for her mom almost broke her, until she called the line at our hospital, and Mike Kekowicz, our ethicist, said, don't worry, I'll take care of it. And she said, then I became the daughter. So we still have access problems because we're the only game in town and it's getting overwhelming for our team. So we're trying to create capacity. Provider resilience is a big deal that we need to work on. The coroner process, as you alluded to, it is hard. You know, they've started when they do the consent process saying to the family, this is going to happen, the coroner's office is going to call after this happens, because it was shocking to them, but it was hard for the team, but it is getting better. The relative silence around the MAID team, because it started with this court-ordered cone of silence, and we never really talked about it afterwards, that is something we need to work on. Also, the patient's daughter last week, her name is Jan Ditchfield, you can Google her, she's a very public figure. She talked about there's nothing out there, you go. She hadn't talked to anybody about this. 3 people knew how the end came, and there's no support out there for family members, and they don't know what to do with it, because when they talk to some people make them feel ashamed and have different reactions. So we need to think about that. Some of the opportunities, though, are also that we can spread the resilience program. We can provide support for the families that are left behind and for the team and be more public. And we need to do better about the intake process and having people know how to access it. So I'll stop.
Thanks. So my comments, if I could just say ditto and end there, that would be very easy for me. But a lot of the comments really echo with my experience. So I'll just say that as an ethicist in a healthcare institution, I'm very intimately involved in all of our MAID cases and coordinate them in a variety of capacities. And then at the University of Toronto Joint Centre for Bioethics, I co-chair a task force there of ethicists and healthcare providers with training in ethics across the province. And so we deal with a little bit more of the policy type issues and also a community of practice for all of us. So I'll just make a few brief comments. One thing that it's a common adage in the ethics world is to say the law is the minimum ethic. So that's really the floor for which we cannot fall below. And in this case, we're not arguing about the ethics of assisted dying, it's allowed. But really thinking about, okay, how can we elevate that and go beyond it certainly has ethical implications. The 3 emerging areas that Maureen noted, mature minors, advanced requests, primary mental health issues, those are certainly areas worth exploring and are being explored further. So it's a really interesting area for discussion there. Since it hasn't come up, maybe I'll talk about a few of my surprises when I first got involved in these cases a while back now. And so one of the first surprises I had was really how profound the conscientious objection was. I certainly could look at poll data and see that majority of Canadians support having this as an option, but as as it comes more closely to actually participating in providing it, those numbers are quite small. And perhaps I was a bit naive in thinking that this general support for the public level might resonate a little bit more broadly. And that's fine. It is still a relatively small number of people that are willing to provide it for their patients, and they're very committed and dedicated. So there's conscientious objection both at the individual level, so individual nurse, physician, healthcare provider, and also the institutional levels. So faith-based institutions, they're permitted to opt out and not provide it. There are referral expectations that Maureen was noting as well. So one of the ways that I try to deal with some of the conscientious objection piece certainly is respecting the college standards and operationalizing that. But before each of our cases, I always do a pre-brief with the team and just say, give the patient's journey. I always think it's really helpful for them to hear, how did the patient end up in this position? It's not, if you just say, oh, they have a glioblastoma, they're 57, that doesn't really give you enough. If you give them the history and the journey of what's important to them, and then talk about, they're really sure about this, and we'll give them the chance to opt out up until the very end. I find those types of information sharing really resonates with healthcare providers, and then give them a chance to ask questions and appreciate what the process is going to look like, and certainly emphasizing that it's completely voluntary. So that's one approach. After a case, we also do a debrief with anyone who wants to attend and just a check-in. And that's more of a quality improvement type approach. We certainly would connect anyone with resources at that point if they felt they needed them further. So there's that piece, and that's, I think the individual conscious objection has been the biggest surprise to me. Just how, what's the word I'm looking for, how strongly it's manifested in some. It's been quite interesting and to see it play out at political levels and that type of thing. So I think that was something that, again, has been a little bit of a surprise, but certainly learn as we go. Probably the third challenge that I'd note is really just how emotionally taxing these cases are. It's really surreal at times, some of the conversations that you have with patients. And some of the comments from your nurse provider really resonated with me when you think about asking them, do you want a meal tray? Do you want to wear your street clothes or a hospital gown? It's very kind of bizarre questions that I find myself asking patients if they're coming in for an outpatient admission. And many of them, I've gotten to know them through their journey, and so it is certainly very touching, and I feel privileged to be part of that. But it is certainly more intense than I probably expected it would be. And so that's been really interesting, and it's great to have a community of practice where we can support one another through these cases. Many of the institutions, ethicists are leading or co-leading the MAID programs, and so we've been fairly heavily involved in that. And I think many are quite grateful for this new opportunity and challenge. I'll just conclude by saying there are a few emerging issues that we're sorting out. So one would be the organ and tissue donation for MAID cases. So there has been at least one organ donation case. I've certainly been involved in tissue donation cases, but that really provides an extra wrinkle into the situation, and it would really have to medicalize the death even more so. So that's something that we're certainly talking about and thinking, how could we meet the patient's needs for a good death, but if they are able to donate organs to others, that we can do it in a manner that would be successful. So those are kind of interesting practice challenges that are emerging that we're dealing with on an ongoing basis. So I'll stop there and look forward to the Q&A.
Well, so I can say that sitting here this morning and as the final panelist, it strikes me that this really, I think, epitomizes what RNAO was hoping for when several years ago we advocated that there be meaningful dialogue on end-of-life care, including medical assistance in dying. So it's a real privilege to be on the panel with my colleagues here. Most recently in March, we did present to the Standing Committee of Finance and Economic Affairs to once again make our voices heard and to really speak to three critical issues that have been referred to today, but I think as the final panelists do merit some just kind of summary. And first of all, one is the issue of access. Medical assistance in dying is now law and part of our publicly funded health system and services, and as such, access is key. So, you know, we need to ensure that medical assistance in dying is delivered in accordance with the legislation. We would never deny access to someone needing dialysis. I can tell you in the most recent budget announcements to hear that safe injection sites may be publicly funded. Should that become part of our publicly funded health services, we would never want to see that kind of service denied. So I would encourage us to think of medical assistance in dying in that same way. So absolutely access is key. Now, we've heard from the panelists the sensitivities that absolutely this is an emotionally highly charged topic, for sure. So we do absolutely want to consider when there is conscientious objection, where health professionals or institutions opt out of that, there absolutely must be a mandatory duty to refer for physicians, for nurses, for nurse practitioners, and indeed for health organizations. I think you've heard from Maureen that that in itself does present some challenges. I think no institution wants to become that kind of focal point for all of those referrals. So I think it is a pretty provocative question. Should a publicly funded healthcare institution here have the option to just say, we're not going to provide this publicly funded service? And I think too, when referrals happen, part of access is timeliness. It's not having some sort of cumbersome referral process that is actually adding burden at a time in life when there is already undue burden and suffering at the individual level and at the family level when they're watching their loved ones suffer. So I do think it is about access, and it is about a duty to refer. We believe that that must be part of the legislation. And we did hear during the hearings when we were presenting to committee the concept of the province actually creating some sort of centralized care coordination, some sort of 1-800 services where Ontarians could access information and indeed access MAID service. So on the surface, that kind of, centralized access point, wouldn't this be wonderful for patients to be able to, and their families, to have this central access point? So, but then let's start to scratch below the surface of that. There's a lot of issues inherent in that for access, timeliness. We're just not sure how that could actually play out in a timely, equitable manner. It seems to me that it would be a pretty daunting challenge for the province to be able to disseminate information on MAID, care coordination, access to this, to patients who are already gravely ill, who are already suffering at the end of life, and now they're trying to access some central service at the provincial level. I think that's just something we would need to think about that. And of course, when you look at already the health disparities that exist, the challenges and access to service in this province, I think about the most vulnerable. So now we're thinking about people at that very vulnerable end of life stage, and I then, an RNAO, in terms of our values base, starts to think of those most vulnerable populations at end of life. Let's think about frail elderly. Let's think about disadvantaged persons socioeconomically, people on the street, people who actually find themselves quite alone at end of life, who aren't surrounded by a community of family and friends to support them. And then we think of those other barriers that happen, language barriers, newcomer populations. There's endless challenges to access. And then we look at, Debra spoke about provider resilience, a critically important dimension. RNAO, we look at the availability of enough providers. What will it look like when you look at health human resource planning to have enough providers of medical assistance in dying and coordinate that care, particularly if we get organizations opting out and we start to see these pressure points on those organizations who will provide the service. But we then see that falling on a few providers and not enough providers in the system. And we believe that as we need to think of health human resource planning across this system for provincially funded services, we need to think about that for medical assistance in dying as well. So in summary, it is about timely access to this service. As the legislation now stands, we are concerned that if duty to refer is omitted from Bill 84, this province will have a challenge where they'll have to implement a whole series of services and measures to enable Ontarians to have access to medical assistance in dying in a timely way. And so, I was reflecting, the theme of the last few days for RNAO has been about values, about evidence, and about courage. And I think this is something that deeply affects the people of Canada and the people of this province. And as such, I think we need to really be thoughtful about the values, about what Canadians want, about what the patients and clients that we serve really want. And then to look at the evidence and to have the courage to speak out and to be here as professionals, whatever that profession may be, to do what is meaningful for people who face this really important part of life's journey, and that's the end of life. So thank you.
So thank you to all our panelists. A really good variety and a lot of food for thought there. I'm going to fire off a couple of quick questions to people, and of course we want people to come up to the mics and ask questions. The only thing I ask is that you actually ask questions rather than give us speeches, and we're not here to refight the MAID debate. We're here to talk about the reality today. It exists, and should it, and how does it work practically? So I'll get to you in a minute, but I'm going to ask a couple of questions of folks up here, and then I'll come to the audience. So Dirk, I want to start with you. Really some rich data that you presented, but the one thing that's not there in Ontario that exists in some other jurisdictions is we don't know who was refused and why. Isn't that just as important as knowing who died and why they chose to die?
So that specifically speaking about, everybody has talked about patient access, and we don't have a good view into patient access. So without that data, we don't have an answer to that, and therefore we can't take steps, generally speaking, to improve patient access without knowing the data. So absolutely, it is outside of my jurisdiction as far as the Coroners Act, because all of that is before. And so that is an issue that is a challenge. There's no question about that.
But some unfinished business there.
It could, I don't know if the business is being built, if there is business. I think the federal government is working to try to develop national approach to when there are requests made to be able to help to understand the access, but I don't have a line directly into that, so I actually don't have the actual answer for you.
And Maureen, we didn't talk a lot about palliative care today, but the thing I hear, and I'm sure you hear it over and over again, is don't we just need better palliative care? Wouldn't that solve everything? Would that have solved Don's problems?
Of course we need better palliative care. Can't say that enough. But Don and I were very lucky. We lived in a part of Toronto that was serviced by the Temi Latner palliative care people. We received excellent palliative care. We also had the family resources to provide most of his care ourselves in our home. And I can still tell you that despite that, Don would have elected to have an assisted death toward the end. So even Larry Liebrack, one of the great fathers of palliative care in this country, said palliative care will go a long way for the majority of patients at the end of life, but there are still always going to be a minority who will want an assisted death. So that's my answer to that. Of course we need more palliative care though. Yes.
And Debra, you talked about all the teams are voluntary at Ottawa Hospital, but do you give them special training? Do the nurses and doctors get special training for MAID, or are you supposed to know this like you know everything else?
That's a tough one to answer. So I think the physicians, let's start with the physicians who stepped forward didn't have any particular special training, but did have a commitment that it was the right thing to do. And our medical director lead, Dr. Vern Naik, he's actually an anesthesiologist, and he was in a leadership role, a VP of Education at the time at the Ottawa Hospital, and he sort of led the charge. So really the procedure itself is not complicated. The intravenous gets started and the medications get injected, and it actually happens quite quickly. Where they have had the special training is in dealing with the performance anxiety, with the feelings they get from being part of it and from supporting the team, and how to make that better for them. The actual procedure itself, I mean, for nursing, it's very supportive care. It might be, anything really that the patient and family needs at the time. It might be starting the intravenous. It might be doing, basic care type things if need be, often not, and some of the aftercare pieces. So it's not anything that is specialized. It's more the emotional consequence for them they've had to have training in.
Interesting. And Sally, you talked about how this can be taxing, it's emotionally taxing, etc. Are there changes to the rules, to the legislation that could make things easier for practitioners, for nurses and doctors, or is it more psychological stuff, or is it, I'm trying to get a sense, could the law make it easier, or no?
Well, I think the resilient support that was brought up by my co-panelists is really important. So I would see it more on the psychological support side than necessarily flaws or weaknesses in the legislation. I do think we can do that better, and many places, such as the Ottawa Hospital, has a really good program in place to support. But I think it speaks further to the need for standardization and consistency, so that it's not just by chance that you happen to work in an institution that has good support. It should be consistent across institutions, that everyone who's participating in this has that support and access to it.
Yeah. Debra, jump in.
So I'm not on the doing part of the MAID team, but when I hear from the clinicians and from the physicians, really the most challenging aspect of the whole process right now is the administrative paperwork connected to the coroner's process, as well as the Trillium Gift of Life Network, and they've found ways around it. And I'm happy to hear that there is a process in place to hopefully start to change the legislation around the coroner's process, because that phone call does come after the end of the, once the procedure has been done. And what our assessors now do is they talk to the patient and family about, what the coroner's office is going to call, and you're going to have to talk to them after this, because for some of them, it was very, very distressing in the beginning, and distressing for the staff. So it is getting better, but that is still one of the things that is, I think, very difficult for the team.
And Carol, you stressed about the access issues, but we're all big city folks up here. The access issues are much more pronounced in Northern Ontario, Northwestern Ontario. How are those solved? Are NPs the solution to that, or what's the solution to the remote access issues?
Well, and absolutely, Andre. I think, when we think about access, we have to absolutely understand, so what are those barriers to access, first and foremost? I mean, I think you look at the big cities in Ontario, there's a tendency for this vortex effect, right? People think, okay, it's available. So I think we have to really look at providers, making sure, to my point about making sure that I think MPs could absolutely, I think about that around many of our publicly funded services, but I think it is about providers, making sure we have enough. I think it is accessibility and understanding the geographic barriers, the socioeconomic barriers. I think it is really appreciating what gets in the way now of people accessing publicly funded services, and let's think about that in the context of medical assistance in dying, right? At the beginning of life, we look at services to barriers to people bringing new life into this world. Many of those barriers exist as people do that life journey at the end of life. So I think it is about really situating this as we would consider service access and service relevance. It's everything from geographic proximity to the right mix and number of providers, to, quite frankly, if I think of Indigenous populations and the diversity of the populations in Ontario, it is also the cultural competency that providers have in understanding all of the needs of the populations and those potential and very real barriers, and how we actually mitigate and actually bring those barriers down. So I think RNAO does not want medical assistance in dying to be considered in any other way than any other publicly funded service. And that is, let's make sure that even in the most remote fly-in communities in this province, that we're considering all of that.
And Maureen, you want to jump in?
I just wanted to say, I think RNs are also an answer. Yes, MPs, but we recognize on our panel that RNs provide care in remote communities, and there is no reason you couldn't use telemedicine to help you evaluate a patient's criteria to access it, and then let the RN administer it. So I think RNs are the answer as well.
And Carol, I want to talk to you also about another thing you talked about, this issue of conscience rights, conscientious objection. I understand that individuals have a conscience, but I have trouble with the idea that an institution has a conscience or any rights beyond, that supersede a patient's. How do we jive that?
Well, I think that is the provocative question, right? And I think Maureen referenced it too. I mean, I think that we do talk about conscientious objection at that individual level, and absolutely this is as I said, highly emotionally charged issue. I do think when it comes to the organizational level, when you look at publicly funded institutions offering publicly funded healthcare services, I don't have the answer, but I do think that's something that we have to continue to work away at, and to really be solution focused when we look at that.
Debra? Yeah.
So just to put that at the level of the patient, so when you have an organization that does not participate in this, they in some cases won't even allow the assessments to happen on site. So this patient who is close to death, who has horrible suffering, has to then travel to a place to have an assessment, not once, but twice, go back and then travel somewhere again to have the procedure. To me, there's something wrong with the system.
Maureen? Okay. She's clutching her lips closely here. Okay. So let's go to questions again. Let us know who you are. Please ask a question, and we'll try and direct it to one person. We'll try and get through the group as quickly as we can. Yep.
I'm not sure who to direct this question at. I don't know who can answer it best.
I'll pick for you.
Just one really quick comment before I get to my question, though, just on what you were just speaking of. Before I left Kingston, they were talking about the fact that KGH and Hotel Dieu are coming closer and are melding as an association, and yet this exact topic came up, and that Hotel Dieu is being a conscientious objector, and so all referrals will then have to go through Kingston General Hospital. But if you're already admitted at Hotel Dieu, then hopefully the physician would move instead of the patient, but I don't know. Don't know how that's going to work. So my question is, if a patient wanted MAID, but the family was resistant, have you had to deal, any of you had to deal with that, or I'm assuming that the patient's right to make that decision should be supreme, but at the same time, like, how do you deal with that conflict that might be within the family?
Yeah, really good question. So Sally, a big ethical issue, lots of junk comes up when people are dying, right? So what happens when there's a family conflict?
So this is a common issue that we do encounter. And at the end of the day, it's the capable patient that's making the decision. But that being said, we certainly engage the family and try to provide supports, whether it's psychosocial support, to have discussions just so that there can be at least some peace or reluctant acceptance at the very least. We certainly try to facilitate that so that there's not anxiety or disharmony in the family at end of death. And in my experience so far, family members that initially expressed reluctance did accept it in the end and were present and grateful for that opportunity. But I think we just have to be very clear that it is the patient's decision, but let's try to get support from the family as well and engage them.
I would be concerned about bullying, right?
Sure.
Like, I'm thinking of my 99-year-old grandmother who's been telling us for the last 9 years, I'm ready to go. Her body's not apparently, but she's ready to go. But her family around her, the daughter that she lives with, is not that person. She's going to hold on. So.
It's family dynamic.
Great.
Yeah,
So,
exactly.
There's nothing you can do.
thank you. So we'll go straight to the next question. Yeah, go ahead. Yeah, I'll go to the back and I'll switch back and forth. So, yep.
I'd like to thank all the panelists for your presentations. Is the mic on?
Yes.
Yeah, thank you. I have a question for Dr. Huyer. It's really about the compilation and dissemination of data on a regular, ongoing basis. I'm involved as an RN on the MAID team at the Ottawa Hospital, and I have been since the beginning, but I'm also wearing other hats, and I'm involved in nursing education as well as education of the public. And one of the aspects about education in the public domain is that I think the public is slowly but surely realizing that this is something, and this is an area that they're going to have to be educated about in order to explore their options and ask for what they want. Because no caregiver is going to say, hey, do you want MAID? Of course, they're not going to do that. So the public has to ask for this for themselves, and they have to be informed. So this comes back to the data question. It was extremely helpful leading up to the months before December to be able to contact your office, and there was always a neat little data summary that came out at the end of the month, which was just extremely helpful for those of us who are educators. But after December, I understand from what I've been told that that function has ended. When I contacted your office just last month, I was told that I could have the numbers. I think I was given the numbers from January to March, but I was told that the nice little summary that I had previously received on a monthly basis that broke down the data in the way that you did, that data was put together for the purposes of a presentation, and that was no longer existing. So I'm just wondering what kind of data can be available on a weekly, monthly basis, and how can we access it?
So unfortunately, you're completely misinformed. You're able to have it. Send me an email. We're developing a distribution list. Wherever that information came from, I apologize on behalf of our organization. It's completely wrong. Exactly what you got is we will give out the slide that summarizes where the causes of death, the age, and we'll give actually the regional distribution.
That's extremely helpful.
On a monthly basis. So if you send me an email, if you get my card after, I'll get you onto the list. We're developing a list. The new team has Sarah Kimmick, who is our registered nurse team lead, is developing a distribution list that we can put on. It'll be about 2 weeks after the end of the month, that we'll do them, and we do it release monthly. So happy to give that to you. No concerns whatsoever.
Well,
we are a public service.
Well, that's what I thought.
Yeah. So I apologize for prior.
Thank you.
So go ahead.
Hi there, my name's Peter Kemp, and I'm a registered nurse in the emergency department. I deal with mental health crisis cases only. And as we've kind of mentioned, there's this case going on in Windsor about a man who, and it's been mentioned I think in your column before and on various media outlets, And it seems like there's this kind of push to expand medically assisted dying as much as possible. But yet I'm also doing a presentation for youth and noticing that rates of distress among youth are also increasing at the same time. So we're seeing more rates of, like higher rates of mental illness and mental distress, and now we're kind of introducing this, well, you may have the option of suicide. And we still don't completely understand mental illness and what causes it and what drives it. And now we're also having this debate where we only get half the information. Like, I think a psychological autopsy should be completed on this individual from Windsor so that we can have a real public debate, because there are mental illnesses that can affect interpersonal relationships and those kind of things. And I don't know if this person is truly altruistic in what he might be wanting to do here, but it looks dangerous when, I'm saying to people, you have to wait 2 months to see a psychiatrist. Even I see people who are, who have actually recovered from severe mental illness, and there's a recovery model in Ontario saying that, you can live with your symptoms, you can get better. And now I'm gonna have patients coming to me in the Emerge, and I'm gonna have to say, well, just wait, maybe you can actually go get assisted dying. So how do you reconcile that? And
I think you should answer.
Yeah, no, I think, Maureen, you guys discussed this on your panel quite a bit. How do you ensure that people with mental illness have capacity, have consent, that it's legitimate?
So we heard from psychiatrists, psychologists, and patients' rights groups. There is no way we'll be able to ever treat mental illness the same way we do the other illnesses. It's going to have to be a separate stream. But when I went into this whole thing, I thought I would never agree that anybody who only had a mental illness should be able to have assisted death. But now I understand, and the psychiatrists were clear, just because you have a mental illness doesn't mean necessarily you lack capacity, and I'm sure you would agree with that, to make your decisions about your health. Can we agree that there may be some people who, after trying everything, may still say, death would be better than the life that I have? Would you agree that there are some people who will be refractory to treatment? A small number?
Is that inherent in many mental illnesses, though? Is that I've seen people who have been locked in seclusion for 2 years when I worked at a tertiary center, and they were happy as pie, but
you wouldn't
aggressive. So it's
so I would never be the one to be able to decide. But I believe if we bring experts together, we may come up with some criteria where they would be at. By the way, I met a young woman from Belgium. She was part of a documentary that I was in, and at the end of the documentary, after 2 years of asking for an assisted death in Belgium, her psychiatrist agreed to give it to her. And so you find this out at the end of the documentary. Finally, they agreed. She's about 28.
And she had a diagnosis of borderline personality disorder as well?
She had severe refractory depression and had tried many, many things.
But a personality disorder, nonetheless.
She's sitting next to me at the screening. And I said, what are you doing here? Like, if you watch the documentary, you would think you wanted an assisted death. And she said, actually, I think one day I will. But right now, knowing that I have that option has allowed me to relax. I'm writing a book. I think one day I will. But right now, I don't need it. And that was very powerful.
We get these patients who will say, if you discharge me, I'm going to kill myself. Well, do we just say, well, there's the assisted dying doctor,
but
go for it?
No. That's so that kind of suicide is
it's a slippery
different.
slope, and I think we have to acknowledge that as we push for more access with less. For chronically suicidal patients, one of the therapies is dialectical behavioral therapy, and that helps refrain this type of thinking about, going to death when you're in distress. That's kind of a coping strategy, and how do you refrain? So, it's expensive, it's long, it's difficult, this type of therapy, and are we
Does it work 100%?
No, but...
Then
yeah,
we're only...
But mental illness is subjective, and nobody can actually know what distress is. So
let's try and get some other questions in. Sally, put it in a larger context. Don't you have capacity, consent issues all the time that are really difficult?
Yeah, capacity.
Are they any more difficult if someone wants an assisted death? Or
I'm sorry, could you repeat that?
Are the ethical issues any more difficult if you want assisted death than if in other parts? There's always things at end of life that are difficult.
Absolutely. Capacity exists in all patient disease groups and sequelae, so that's not unique to assisted death. But I think, as Maureen said, I would strongly agree there would be a separate pathway for mental health, most likely to make sure the concern is always vulnerability, and that people might choose an option and have a limited life than what they should otherwise is certainly a concern. But I noted the gentleman said, a slippery slope, and I have a personal allergy to that terminology. So I always push back and say, we don't live in a boundaryless world. There are parameters, there are rules that can be put into place. And I think absolutely if we do open it up to mental health diagnoses, it would have to be done very thoughtfully, very collaboratively, and very rigorously, but I don't think it's inevitable that we're going to fly off the rails if we go down that route.
So let's go to another question at the back. We're just talking about having a little more time. If people have to sneak out, please do so discreetly, but I think given all the questions, we'll keep going. We have the room for a bit of time if I'm seeing nodding heads, so we'll keep doing that. So ma'am, at the back, let us know who you are and fire away.
My name's Maria Rugg, and I'm a long-term clinical nurse specialist, advanced practice nurse, and palliative care for the last 25 years. I want to thank the panel for a really informative and thoughtful discussion. It's been a mainstay of my practice experience for the last number of years. And I guess I'm wondering if anyone on the panel can comment on something that has been continually in my thought process, which is really just something that has stayed with me from the time of Larry Liebrack and the time that I spent with Larry as one of my mentors, but just the idea that while palliative care can exist without MAID, but MAID cannot exist without palliative care. And I'm just wondering if anyone on the panel can comment on that in terms of the idea of where's the quality control with this process. Thank you.
So Debra, do you want to talk about that? Where's quality control? Are people getting better palliative care because MAID exists? A lot of jurisdictions have shown that in the research. Are they getting
honestly, I think, as Maureen already said, palliative care is critical, and we need to do a lot better in a lot of areas with palliative care. But many people who enter into the MAID process, from my knowledge, have been through excellent palliative care. And they've gotten to a place where they say, you know what, enough's enough, I don't want to do this anymore. I'm probably going to die in the next short little while, and I want to control how that's going to happen. So, and I can't remember exactly what the question was now, but the quality control, they're two separate processes, and yet they're part of the same continuum, and you need to think about it that way. But the quality control is the legislation, and it is the coroner's process, and there's very, very particular criteria for who's eligible and who's not. And one of the biggest things clinicians struggle with is telling people that they're not eligible for whatever reason, or who were eligible and the day comes and they don't have the capacity anymore. But the rules are there right now. We talked about wanting to expand them, but so I think there is quality control in process, and MAID doesn't preclude palliative care. They go hand in hand, and people can choose how much or how little palliative care they want to go through before they decide that it's time for them.
And Dirk, do we know in the data, does it tell us whether people have been through palliative or not?
Well, in fact, it's legislatively required that palliative care is offered, but I think that it's much more important and much broader than a checkbox. And that is a challenge that we're facing as a team. Maureen, I thank you for raising the question. And Maureen, I think building on some of the comments that you made earlier, we don't know how to measure. So we'll ask the question in our review, was palliative care offered? That's a checkbox. That is not a solution to figuring out the quality of the palliative care. And I'm struggling with the team. This is an example of how we're trying to evolve and mature our process. I'm not sure how we could ever retrospectively go back to figure out what was the quality of care, the quality of palliative care that was offered, and the clinician who was offering that palliative care. So I think it's a really, and I'm not suggesting it's good or bad. I'm just suggesting we as a healthcare profession need to build on everything that everybody's talked about, the need for good, solid, competent, capable, available palliative care, and how we, as our own organization, the Office of the Chief Coroner, trying to figure out how we can inform that is what I'm looking at.
One thing we'll have to do with palliative care is make sure that we start to think of palliative care for diseases other than just cancer. Because right now, if you think about someone with multiple sclerosis who's becoming more and more disabled, how often are they offered palliative care as part of that ongoing process? So I agree with you that we shouldn't think of MAID being offered without palliative care, but now we need the palliative care community to start to expand, we need the resources for it, to include these non-cancer patients who will be able to access MAID, but should also have symptom relief along the way and support from palliative care.
And Debra, you had another comment?
No, it's okay.
You're good? Okay. So we'll go here again. Yeah.
Hi, my name is Larissa Gadsby. I'm a pediatric nurse practitioner working in pediatric neurology. I just want to thank you so much for such a rich discussion today. It's definitely very thoughtful and lots of different questions coming to mind. My specific question is actually around the conscientious objection piece, and you were talking about the resiliency program that you have with your staff, and I think those of us in pediatrics are very aware that this is not something that will be unaffected by, especially when we're talking about that area of mature minors. And so my question is, what support is given, whether you have faith-based staff who acknowledge that, you know what, for the best care of my patient, I choose or would like to support their wishes, but are perhaps afraid of repercussions that that choice might have, and even non-faith-based staff who, even within the organization, come forward, and what ramifications could they feel from their own staff members for taking part. And so I'm just interested to find out a little bit more about that support process and how the culture is being shaped within the organization to prevent things like bullying for their choice to address the patient's wishes.
Great. Debra, maybe you could address
So, our team, right from the get-go, any communication that's happened within our organization, and there was a lot of discussion more broadly than just the team working on it, and it's been very clear from the very beginning that people who were not comfortable for religious or other reasons to participate in the process absolutely do not have to participate. Our teams right now are all completely voluntary, and we have had times when, as I say, a patient, they've had the MAID procedure on a unit, and the nurses who are caring for the patient on that day, if they're not comfortable participating in it, they can ask to have their assignment changed, and it will be changed. And so I haven't heard of any bullying or things that have been happening around that. I've heard some comments around the nurses who are potentially on the MAID team, but I have not heard of that. So that is something we need to keep a very close eye on, because I think it is important that this is voluntary. Having said that, and even with the College of Nurses standards, that if someone does identify to you or they are going through the process, we still have a duty to care for them until we can transfer the care to someone else. But it hasn't been an issue to date, but it is something we need to watch.
I guess just to clarify, my question was more around those who want to participate but don't, because of the the fear of what will my colleagues say about me.
Oh, who want to participate on the MAID team, but they haven't been?
To, what's the culture in that?
I haven't really had that. As I say, all of our volunteers at the moment have come from the critical care unit. I guess it is possible that there are some people who won't step forward to be part of the MAID team because their friends or their family or their colleagues might not approve, and I think it's a very personal decision. If they did come forward to the people on the MAID team, I'm sure that there could be support in talking through that, but ultimately it's what they're comfortable with. They might want to participate, but their value for not rocking the boat with their friends and colleagues and family might be different, might be stronger.
Thank you very much.
Let's remember, number-wise, there's about 34,000 physicians in Ontario. 120 have provided MAID to date, so very small. I'm not good at math, I'm a journalist, but that's 1/3 of 1%, I think. So we'll go to the back.
Hi, my name is Romney Pirog, and I'm a frontline registered nurse. I work in the critical care float pool at Kingston General Hospital, and we have been a part of MAID. And so my question is, again, about provider resiliency. So I'm looking for resources for staff and family, because I've been asked by the organization to develop those, and I've looked far and wide and I can't find any resources. And the reason for that is because we've had some cases and we've had some unexpected symptoms of secondary traumatic stress after the experience, even though they've volunteered. And it's usually just with the first experience. The second experience is better. These are people who really want to be a part of this, really believe in it. So I was just wondering if we have any, who I should talk to up there after, so I can get their card to maybe connect with them.
So why don't we just touch base when we're done here, but for sure our team, it was being offered by a team specifically at the Ottawa Hospital, but they've now developed a tool that can be disseminated and they're ready to share it. So let's just connect right after this and I'll give you the name of the actually if you email me, I can connect you by email.
Okay, thank you
so we
very
can
much.
connect afterwards.
Okay.
And I think for Doris, I think I'm hearing over and over that there's a need for a workshop on resiliency coming, so should duly noted. Okay, guess go ahead.
Hi, and thank you very much. My name is Eric Rankin. I'm a primary healthcare nurse practitioner, and I work at Dirk Aboriginal Health Centre in Brantford area. Thank you very much for presenting. Quick comment about Maureen and mentioning about registered nurses being involved with and being able to assist us, whether it's through telehealth. I work with the Indigenous population in fly-in communities, and that's a perfect example. I'll get right to my question. It's for Dr. Bournes. Being a nurse practitioner, with your experience with the Ottawa Hospital, are nurse practitioners being utilized to their full scope of practice with regards to MAID? With regards to MAID, so at this point we haven't had any nurse practitioners who have volunteered to be part of the process. It doesn't preclude them from being part of it, but the physicians have been fulfilling that role up until now. It doesn't mean that they won't in the future. We don't have a lot of nurse practitioners. Most of them are in the outpatient area. So, I mean, that could change. We're currently in the process of changing that as well. So we'll see what happens as we go forward.
At my hospital, I'm so proud. We have 3 nurse practitioners, and every one of them has stepped forward to do second assessments already. And I expect that with the new law allowing them to prescribe the medications that they would be willing to administer. And I'm so proud of them. So yeah, ours are like right there.
Ditto for me as well. At Sunnybrook, we surveyed both physicians and NPs in terms of availability or support for participating, and resounding support from the NPs, and they have been integrated, and we're training them up to be primaries once they have that competency.
Can I just add, I just want to be clear that, so it's really been a physician-driven process from the assessment perspective, so we haven't actually gone to the nurse practitioners and say, hey, so they haven't said they don't want to, and I'm sure they would potentially be open to it in the future.
And Carol?
Yeah, no, I just wanted to speak a bit further. So, I mean, when I think of nurse practitioners, and Eric, you stood up first and foremost as an RN, I think we absolutely need to look at optimizing the contributions that RNs and NPs can make in the system writ large, okay? I think medical assistance in dying is no exception. I do think, though, that back to my point about access, I think we have to also look at what are the barriers, the systemic barriers that exist baseline to RNs and NPs practicing to full scope. And they're alive and well in the system and have been for too many years. So I think this medical assistance in dying is surfacing that yet again. And I think whether it's RNs and assessments, we don't need to go to remote communities to see that that's underutilized. That's underutilized sitting here right in the heart of Toronto. So I would just say, make a pitch for RNs and NPs being maximally used to full scope of practice across the system in every way. Medical assistance in dying being one example.
Thank you. So, thanks. So we'll go to the back. We have 2 more questions, and then Doris will wrap up for us. So,
I'm Kim Watson. I'm from Windsor, Ontario, and I'm an emergency trauma nurse there. Kudos very much for looking at this role at the beginning and the impact with the resiliency. But given the fact that PTSD is not even being recognized in the legislation, that nurses, that this is even impacting us, now that we're adding this additional role where you're already looking at resiliency and providing programs when the vulnerable populations of nurses out there already are not even being attended to, and their needs for resiliency and everything isn't. Are we not piling something on more that we are not pursuing this from the legislation point of view, that this is going to open that door even wider, and why are nurses not being included in PTSD legislation and protected?
Well, Andre, I'm going to just respond to that. We are actually, RNAO is absolutely pursuing that. Yes, Doris? It is. Yes. Yes. So stay tuned.
And I know RNA is.
Yes.
I'm keeping it out there because we need
That's
this.
right.
Yeah.
We have been in active pursuit, and it's imminent.
Yeah, and I'm talking to greater than RNAO. I'm talking to the panel up here that we need them to also recognize and support the fact that nurses need to be protected. And when we're looking at a role like MAID, which I totally agree, like I think it's just so fabulous you've done this, yet for years other groups still are not even recognizing the fact of what nurses deal with each and every day. I've been 41 years a nurse, emergency room since '82, and it still is sad when that legislation passed that other groups weren't outraged and standing up there and saying, this is ridiculous. Yeah, but thank you.
Alors, est-ce qu'on va finalement avoir une question en français?
Ben, je vais vous en donner une.
Okay.
Mon nom est Paul-André Gauthier. I'm the clinical nurse specialist in palliative care. And I'm also the chair of the Sudbury Manitoulin Ethics Network. And we have been having these discussions for the past 2 years because it's the main topic of the monthly meetings. So having said that, my question will be about prevention, but I want to raise a few things because we need to help our colleagues and the nurses in doing better what we're doing in order to provide the care. I attended a presentation this week in French, and it was about the research done by the physicians in Quebec. And the issue was, how do the physicians perceive euthanasia? And right now, they're in the process of replicating this research, but at the national level. So I'm giving you a bit of data from the previous results. Physicians are confused with what is euthanasia. One of the elements that came out quite strongly, refusal of treatment was perceived by physicians to be euthanasia. Then down came pain control, perceived as euthanasia. And if they do the pain control, they associate that with euthanasia. And the other one that going down the scale was withdrawing of treatment being perceived as euthanasia. So my question is, in order to help people and professionals, start with the professionals and physicians and the other healthcare professionals, what are we going to do to help them to understand what is really euthanasia and what is not? Because right now, the hospice in our regions, one of the things they're saying, they don't want to do MAID for a reason they already associate with euthanasia. People say, oh, they kill people there, don't go there. Okay, this is the confusion we're running into, and that's why in our region we're educating the public, but it takes so much. But right now, I think we're forgetting one thing, to educate the professional to understand it, and also the public. What is your take on this?
So thanks, that's a great question. That's a point I wanted to actually address and didn't get to in my comments. So one way to do it is just definitionally. So in our policy template that the Joint Center for Bioethics issued, in our definition of MAID, we are very clear, it does not include withholding, withdrawal of treatment, or palliative care. So that's one way, but there's also just the education component, right? So what I typically do is say there's 3 facets. There's the intent, there's the causation, and then the agency. And so go through each of those elements with withholding versus withdrawing and MAID and show them how it's key, there are key differences with each of those. And typically people understand once you're able to walk through and emphasize those 3 different areas. I'm happy to chat with you further afterwards if you'd like.
Thank you. Other people?
You know what would help some of this? So it disturbs me that there are physicians out there who do not understand the difference. But if we could take more of this out of the hands of physicians and more power in the hands of patients, what would help, we were talking about this before, is an oral medication that I could take like secobarbital like they do in Oregon, so that all the physician has to do is write the prescription, and then I get to take the drug in my home with my family around, and then they don't have to feel like it's euthanasia. My husband died with terminal sedation. The brain tumor didn't kill him. His kidneys shut down because we didn't give him any fluids for 7 days. So any physician who doesn't understand that it was the terminal sedation that killed him, it's a form of euthanasia that was entirely legal and under the circumstances the most compassionate thing that could be done, then they don't understand end-of-life care, I would say, about those physicians.
So just to clarify, if the physicians who are knowledgeable professionals do not understand the difference, what about the public? I didn't get that. We're talking evidence stuff there.
That's why we
if
have
we're talking
André
about
Picard.
evidence stuff, I suspect that the confusion is greater because in my clinical experience as a specialist in palliative care for the past 26 years, is people said, oh, if I take pain control, I will die and this and that, and you're kidding me. I said, no, we're not. Pain control is the basic stuff we should be doing. But public is probably, the understanding can probably be worse if we find the studies about that, because I didn't have time to look at it. Anyway, just food for thought.
And I should note the Quebec, which is obsessed about collecting data, actually collects data on terminal sedation as opposed to MAID, and it's about 50-50 now. So terminal sedation, as you've noted, has been around forever. That's how my parents died, and many elderly people die, and it's quite accepted, but we don't count it differently.
Hear about it.
Yeah, we don't talk about it. So I see you snuck in there after I said 2 more questions, but go ahead.
If that's okay. My name's Amanda Dodge. I'm a new grad in Emerge, and it was actually, my question is very close to Paul André's. I had an experience in my second year. I was an observer actually on my own time in a critical care trauma center. And this is something when MAID legislation was coming out, this day really stuck with me. This patient came in with a hypoxic brain injury. He was in his 80s and no capacity to make decisions. He had a POA who was very well versed in this gentleman's future wishes, and the nurse I was paired with that day, he was on a vent, spoke of the time window that was neat to make the decision where you could actually take this patient off the vent before his body would adjust and could basically live as a vegetable. There was that window, and this decision to withdraw care needed to be made in that time. And to me, we still gave a cocktail of meds. This patient was sedated, and without, like I said, without capacity, and this was somebody else making this decision, and we withdrew that care. And to me, when you speak of conscientious objection in the same building upstairs, I couldn't delineate between the two. A lot of the medications were the same that we were pushing through the IV, and he had no capacity. And so I've struggled when people speak to that conscientious objection, but how is it really that different to me and so to tackle that with the physicians and NPs in that hospital that raised that the next year in a palliative discussion around MAID. I don't know if anybody can speak to that, and in
Maureen,
that
do you want
difference.
to talk about those
I want
borderlines?
to offer you a job.
Yeah.
I want to offer you a job. If you want to come work with me, I'd love to have you come work with me. You've just done a great interview. I'm going to step aside to my colleagues now.
It's interesting, isn't it, that they do that delineation. I have my boss, who's an infectious disease physician, knew my late husband. He's thrilled that we have the legislation, that it's an option. But he also said to me, he said, I don't know if it's because I'm an ID physician and I'm not a trauma, palliative care, or whatever, family doctor, but he said, I personally don't think I'd be able to push the meds in, although I'm cheering on everybody else who does. And he's not exactly a conscientious objector per se, but he's I just don't think I personally can do this. So I have a lot of time for conscientious objection and that personal, I don't know that I can participate. All I can tell you is, and I'm never going to be asked as I'm a PA, I could push the meds for people who have delineated a clear, constant wish to die on their own terms. I could do it. That's all I can tell you.
Thank you. So on that note, I want to thank the audience for your active participation, for being there, great panel, and Doris is going to say a few closing comments. Thank you.